Yeah, Liu, Dr. Wang. So everyone, good morning. So it's a warm word of welcome to everyone for attending the ISUBE 2022 webinar France station. I'm Dr. K. Yu, working in Peking Union Medical College Hospital in China. It is delight to have all excellent spinal surgery experts with us today, and a special thanks to those who have been dedicated in UBE technique development. More and more spinal disease patients get benefits from the spinal innovation method, including the UBE. So with conducting our UBE in primary hospital in China, I'm absolutely sure the UBE technique will have many milestones in the future. Today is a very important milestone in worldwide UBE technique. And I want to take this opportunity to thank Dr. Jean Charles Rachu and Dr. Maxime Chari and all other spine surgeons, colleagues from supporting today's conference. And I hope the COVID-19 pandemic can be combated in near future. And I am welcome you all to China for a person great for in the future, the great UBE event. So now, I also have a very special thanks to Bond's company's wonderful effort in pushing UBE technique development in China and also in all over the world. And I hope you all enjoy today's conference. Next, Dr. Zhang Wei from Hangzhou. He's going to give us amazing live UBE surgery. And we will welcome Dr. Zhang Wei. And I also will introduce our discussion panel. They are Dr. Liu Zheng from Peking Union Sougan Hospital, China. Welcome. Dr. Luis Porfirio Sanchez from ISUBE Hospital, Mexico. Welcome. Dr. Hamatia Mahaditap Tanglan, General Hospital, Indonesia. Welcome. And Dr. Slavi Liska Gatan. Dr. is from Fatmawati General Hospital, Indonesia. And also Dr. Kanji Sasaki Sari Himamatu is from Japan. And Dr. Wu Wu Panghua from NG Teng Feng General Hospital, Singapore. So, and welcome all the colleagues and from on-site and also on the online. And here I also would like to introduce Dr. Liu Zheng from Peking University Sougan Hospital, China, to introduce a case report from Dr. Zhang Wei's live surgery. Please, Dr. Liu.
Hello. I would like to introduce two cases which will be performed by Professor Zhang Wei. 我需要共享屏幕吗？
Yes.
他不让我那个主持人不让我共享啊。我主持人不允许我共享屏幕啊。
工作人员
在吗？
共享屏幕那个启动一下。这现在可以。
好，行了。
可以了 ，OK。Please。
这个人稍微等一下。可以看得见吧？
看得见 ，OK。
Case 1, a 51 female patient. Her chief complaint is low back pain with both buttock pain, and MRI and CT scan shows lumbar central canal stenosis at L4-5. And Zhang Wei's operation plan is to ULBD at L4-5 by left approach. And case 2 is 40-year-old male patient. His chief complaint is right low limb pain, and MRI shows downward disc fragment and foraminal disc herniation at L4-5. And Zhang Wei's operation plan is the UB. Is UB foraminal decompression by contralateral sublaminar approach and UB discectomy by contralateral translaminar and Zhang's portal for the third incision. That's all. Thanks.
So let's move to the live surgery. Okay. Dr. Zhang Wei, can you hear me?
Yeah, yes, I can hear you.
Okay, let's start.
Can you hear me? Can you hear me?
Yes, very clear.
Yeah. I'm Dr. Zhang Wei from the Hangzhou Traditional Chinese Medicine Hospital. Today, this is my first living surgery. This is case 1 about the central stenosis in L4 and 5. Now I have build the portal. You can see the left side is cranial side, the right side is the caudal side, and above is the midline, below is the facet joint. Now we will performing the bone work.
Okay, Dr. Zhang Wei, we cannot see the screen. So,
yeah, I can hear you.
我们看不见你的那个显示。
那个显示给
切换一下。
把那个切换一下那个手术。I feel very glad to perform the living surgery with my teacher, Master Dawson. My sister is Dr. Zhu Chengyue. Okay. 还没切换呢。
还没切换过来。We cannot see the video.
Okay. Wait for a moment.
Okay. Okay, now we can see it.
Okay. Now I have I'm doing the bone work. First, this is the lower margin of the L4 laminar. I use the diamond burr to make thin the laminar. You can see the basement of the spinal process.
Yes, Dr. Zhang Wei, can you show us the medial or the caudal and the cephalad side?
Okay, I will show it again. The left side is cranial side. The right side is the caudal side. Above is the midline. Below is the facet joint.
Okay.
Today I use the 30-degree endoscopy for this case. The patient has the two-side symptom, so I will do the ULBD.
So may I introduce the audience, maybe some Chinese doctors, okay. So I will also speak in Chinese, okay? So 现在那个我们那个张教授现在做的是145吧，是吧 ？ULBD 是双侧的那个，他那个12点是我们的内侧，6点钟是我们的外侧，然后那个3点钟是我们头侧，那个9点不是 9点是我们头侧，3点是我们的尾侧啊。OK，
是的。This area is the basement of the spinal process.
Dr. 你也可以 ，Dr. Liu，any comment or？
神经玻璃。
老外也在线上吗？我们就在跟老外讨论吧。
都有嘛，中文尽量用英文吧。当然，中文我觉得有重要的地方就讲一下嘛。So, any questions? Oh, welcome, Dr. Gupta from India. Welcome. 他那个字幕 ，you can see the message, okay?
So, maybe I can ask Professor Zhang Wei today, why do you use 30 degree or why not 0 degrees scope?
Zero. Because I have only the 30 degree endoscopy. But I think 0 degree is also a good choice for the ULBD case. But if you use the 30 degree, you must learn how to rotate the endoscopy. So later I will show how to rotate the 30 degree endoscopy.
Okay. So how about Dr. Wu? Do you prefer 0 degree or 30 degree?
I use 0 degree most of the time. I use 30 degree when I do contralateral foraminotomy or I want to do a fusion and I want to see the more further apart structures. Then I use the 30 degrees. I find that it's easier to train people with 0 degrees. The learning curve probably is less steep.
Okay. Dr. Wu 就是我给中国的那个观众介绍一下，他就是问在 Dr. Wu 在新加坡的，他喜欢0度还是30度镜？他说他平时用0度镜，做这个融合或者做椎间孔入路的时候，他喜欢30度，可能观察范围更好一些。然后他觉得对0度镜来讲呢，这个大家掌握起来更容易，更加学习曲线更加平缓一些。OK，Thank you. So welcome Dr. Diego Curio from Mexico. Welcome.
Sure. 好，上去。I think the orientation of the endoscopy is very important. Now we can see the color. This means the midline of the flail ligament. I remove the laminar until I see the insertion of the flail ligament. Then I stop. Yes, you can see the insertion of the proximal, the insertion of the flail ligament. This is also a site where there's too much bleeding. Because there too much the small vessel on the surface of the dura.
So Dr. Zhang Wei,
Okay.
how much you will resect the proximal lamina? So how to measure it, or so what's your experience?
I will show you. This is proximal insertion of the flap ligament, and this is midline.
Recording in progress.
Spinal process, and I will remove the more bone of the basement of the spinal process.
Okay.
This is a high speed burn. The diamond burn, I think, is very safe. And okay, this is another important anatomy. We can see this corner. I mean, another corner. You can see here is very safe for the bone work. So I will start bone from here.
So I also translate some in Mandarin 啊。那这个刚才张伟教授，他是从中线我们可以看到那个环带的裂隙啊，然后他现在这个处理的这个在棘突的根部啊，在棘突下围弓，它有个 corner， 这地方再进行这个过顶的是比较安全。So welcome, any comment and questions, okay?
Because there is in this here in this area is dangerous, but I think this area is safe.
Okay.
在保护鞘的毛蛋准备一下。
Professor Zhang, what's the diameter of your burr?
About 4 millimeter.
4
millimeters. So I know I rotate the endoscopy. We can see I will find the bleeding area. I use the blue pedal to control the bleeding. Now I change another bone with a protective sheath.
Yeah, I like to use this type of protective sheath as well. I think they are very helpful.
This ball is different from the shiver ball because this is a high speed ball. The shiver ball has a low speed, so I like this one. It is produced by a Chinese company named Zri company. The IF is also produced by a Chinese company named Bounce. Okay, I will rotate the endoscopy again. Then we can see the medial margin of we can see the medial margin of the facet joint. First, I will mix in the medial margin.
Or contralateral?
This is ipsilateral.
Ipsilateral.
Yeah.
So, Professor Zhang, you use two different burr.
Yeah, I
with
use
sleeve,
two different
one
burr.
without sleeve.
Then I change the common one. I make thin the medial margin of the facet joint. Then I will use the osteotomy to remove the medial margin of the burr. 找那个摆具找一下。
Professor Zhang, how to confirm the lateral body of a decompression area for the ipsilateral
in
side?
my opinion, I'm according to the soft tissue.
Personally, I look at the tip of the superior articular process. Once I can see that, I think we have enough inferior articular process resection. Oh, that's a very interesting instrument. What is that, Professor Zhang, you are using?
I use this one.
Oh,
Like a saw.
You have so many gadgets, Prof.
But I don't know the word. Maybe my assistant knows his name of this board. Oh, okay.
Okay.
Your turn.
The saw. Yeah. It looks like what we use in to do carpentry. Okay. Was very nice.
This is a medial margin of the IAP. After removing this bone, we can see the medial margin of the SAP.
张伟说这个是下关节突的边界。
白机不要了，换普通模咱们。好，射频。Yes, this is the medial margin of the SAP. This is the medial margin. Now, another important anatomy is the corner. We name another corner is here. Under the corner, we can see the nerve root, the junction of the upper margin of the laminar and the medial margin of the SBE.
这个上关节突的内侧缘，跟那个上关节内侧缘跟下位椎板上缘交界处。
I use the RF to remove the superficial flexion ligament. It's very safe because there is the deep layer of the flexion ligament.
看见那个吗？
啊？什么？
屏幕不是全。
好，换项目先。The decompression starts from here. We can see the distal insertion of the flexion ligament. 哦，2毫米，对，3毫米的。哇，这个整块的环韧带。I remove the ipsilateral flavial ligament totally. Unblock, remove. So I think today I'm lucky.这个行。小射频换一下吧，换一下小射频到时候3000的3毫米的。This is a corner area. We can see the L5, ipsilateral L5, the nerve root.在弧度的旁边。For the ipsilateral decompression, I prefer to use the curved kerosene punch. This is a 3 mm curved kerosene punch. We can see the axillary area of the nerve root. Angle. This is the nerve root.上去，对。射频。
Claro, bien. Gracias, no. Que poco a poquito sí ya está hecho. Ya hasta se acostó en la cama de la laica. ¿No? Ay, se acostó. No, ahorita dame.
This is the nerve root, L5. 这块钱。
这位，来，行，啊，
真不利。
行，呀也是没有，啊，那，哎呀，
拉钩准备，这块钱再准备。大哥。3毫米的那个，不是大的射频。嗯。Now I recheck the nerve root。好了吗？OK。真不利。This is the shoulder, and this is the axillary area. Now I finish the ipsilateral decompression. Then I will do the contralateral side decompression. 大射频。We can see the too much the blood vessel under the contralateral side flap ligament. We will do the bleeding control first. 向前。This is the basement of the L5 spinal process. This is a superficial flap ligament. Một lần. 射频。真不利。向前。这个题。向前。真不利。大一点的真不利。
Así que bueno.
哎，我上次。
Y que bueno. Eh? Quais carros? Não. É,
Emboli. You can see the contralateral side, the facet joint. This is the contralateral side of the IEP. This maybe is the SAP. Here we can see the SAP, the medial margin of the SAP.
Ya se cansó la otra. Y estaba durmiendo. ¿No? Sí, la está durmiendo.
Unbelievable. 安全吗？好，这块钱。安全。再不差一点。 还可以两方面。We can see the facet joint, the contralateral side. I will do the decompression of the lateral recess. This is the contralateral side corner. The contralateral side is the upper margin of the laminar and the SAP. 上前两方面。准备引流管了。射频，是小的吗？大幅度，这块钱。
No tuvimos cauterizamos, no, no, pues no hay nada de vaso, ¿no? Para nervio me llegó a dar sin caminar. Eso
This is a contralateral side nerve root.
Claro, con Lucino ahorita. Digo, Lucino, digo, hermano, parece que me voy a rebajar al proyecto, porque tengo un montón de gastos, matrimonio.
Tango.
Me había contado, le digo. Dice, no, tranquilo, yo me bajé del proyecto. Porque estoy analizando que no va a llegar. No quiero estar apretado.
¿Qué te hizo ver eso?
Yo no.
Embolismo.
¿Qué pasó?
No, no hay con idea que tenía que recuperar eso. Que estaba en eso. Estuve haciendo cálculos, no llego. Y otra porque se me viene lo del laboratorio campo. Yo tengo, pero ya
This is a contralateral side of the nerve root. 在弧度的3毫米上前。
No, tranquilo, entiendo, hermano. Me dice, pero si Omar, si quieres trabajar en la clínica donde vamos a estar, sí me gustaría que vengas a trabajar. Le digo, no, eso sí, cuenta conmigo. De última, más adelante que te estabilice, y cuando con el proyecto del tomógrafo, yo te aviso. Le digo, sí, dale, dale. Pues yo estaba en...
What's the water pressure you use, Professor Zhang?
Le dije así.
来射频，大射频看一下， 往下一压，
Tuve que mandar 10
Now I retract the contralateral side nerve root.
La verdad es que no es que no tengo, pero no quiero quedar apretado, no le quiero quedar mal. Y tampoco quiero decirle que me esperen, porque no es justo para el resto de gente. Así que... Estoy forzando. ¿Quién me dio eso? Estaba brindando.
Professor Zhang, when you retract the nerve root and use this radio frequency device, do you decrease the energy setting?
No.
Energy about
Energy setting
7 and 3. We can take a picture of the energy. Yeah, 7 and 3. 你拍一张照片给他们看看能量。No, I will use the blue one. Blue one is I can shrink the disc. The contralateral side of the disc. Oh, okay.
Entonces, ¿por qué te estás echando para
Porque yo tengo pensado otras cosas en la cabeza, porque ya se me viene lo de acá y quiero meter allá. Lo de laboratorio.
Yes, I finished the whole procedure. You can see the axillary and the shoulder. This is the nerve root, and this is the pedicle. Medial margin with the pedicle. This is the shoulder area. This is the axillary area. So I finished the whole procedure. Thank you, everyone. Then I will begin the second case.
Yo tengo mi cuenta 16.000. ¿Qué 500 que me dé? ¿Mató 8.000? ¿No? O sea, y para mí no usted invertir. El tema es que acá, bueno, me puse a pensar ahora. Para eso los meto en el laboratorio de una.
Okay, thank you, everyone.
And comments? So, very good.
I will perform the second case. The second case maybe is not easy for me, but because there is a disc fragment downward, and there is also a disc fragment in the foraminal area, so I choose the contralateral side approach.
Great job.
Thank you.
Congratulations.
Thank you. Talk to you.
Any comment or any question?
Ahora, abrí la tortilla. Me cuesta cuánto y me estaban que me querían llevar.
Dr. Zhang Wei.
Hello.
So can you introduce your strategy? I mean, the sequence of your UBD decompression.
You mean this case?
Yes.
Maybe tomorrow morning I will tell you. Oh, the results of the. You mean the sequence? Oh, I know the.
No. I mean.
First, I prefer the abyssilateral decompression. Then I will find the proximal insertion of the flav ligament. Then I will do the decompression of the corner area. After decompression, the abyssilateral nerve root. Then I do the contralateral side of the decompression. I like the envelope remove of the whole flav ligament, because I think if you use the kerosene punch to remove the flav ligament piece by piece is not very safe. But if you find find the boundary of the flexible ligament, you can remove the whole flexible ligament totally. So I think it's very safe. But you must know where is the bleeding area, especially in the proximal area, the corner area. I think you will do the bleeding control by the radio frequency first. Thank you.
So thank you. Great job. So how about Dr. Liu? So what's your opinion?
Very wonderful job. No comment.
So you will decompress ipsilateral nerve root first or contralateral?
I will perform the contralateral side decompression first, then ipsilateral side. And I wonder how to control blood bleeding. Professor Zhang.
I think I will introduce my anesthetist. She is very excellent. He can control the bleeding blood pressure and make enough the muscle relax. I think this 2 points is very important.
Muscle relax.
咱们血压多少？
不是吧？
Very good. The blood pressure during the whole procedure. Then I will use the radio frequency to do the bleeding control. But in this case, I do not use bone wax. But I think, especially in the basement of the spinal process, we'd better use the bone wax. Maybe after 2 days, you will check the MRI. If you use the bone wax, maybe you will get a good quality of the picture. I think.
Good quality picture.
Good quality of picture because there's no too much bleeding in the spinal canal. If you use the bone wax.
我就稍微解释一下吧，张伟说的话，那个我就问他怎么控制出血，怎么控制这么好？输动机会呢没有什么出血的人，视野非常清楚。张伟说他一个肌松药，一个肌松药，一个控制血压。第二个呢，他说在主要的出血者用古蜡，有的时候他会用古蜡，但今天没有用古蜡。他说用古蜡地方最主要在棘突的基底部。你看那个地方可能用古蜡，用古蜡的话，术后的片子会相对比较好看，因为没有渗血，就大概这个意思。
Okay, so there's an audience question. So which kind of anesthesia do you have, general or sedation? Okay.
Oh, general anesthesia. Because we work in the multi-feeders area, so we must get the good muscle relax. Then we can get the enough space to do the work. So I prefer to the general anesthesia.
Hello, Dr. Harman. Yeah. Dr. Harman, Dr. Rizky, and Dr. Takaki.
Yes.
Do you have some questions or share your experience for the UBE technique?
Yeah, thank you. Great demonstration, Professor Zhang Wei. I have a couple of comments. First of all, for lateral recess decompression, you like to use a straight Harrison punch or rather you use a curved one? Because in my opinion, personally, I like to use the curved Harrison punch. It's easier to get the detachment of the lateral recess flavium ligament. And the second, for bleeding control of the epidural vein, I like to use the small hook ablator that bones have rather than the side ones. What's your comment?
Yes. For the opposite lateral decompression of the lateral recess, I prefer to use the 3 mm the curved Harrison punch because of the block of the IEP. So if you use the straight one, is difficult to remove the medial margin of the SAP. So I recommend you to use the curved Harrison punch. For the bleeding on the surface of the dura or the nerve root, you can use the big one or the small one radio frequency, but you must lower the energy of the radio frequency. I think this is very safe. Maybe 2 or 3 is safe.
Okay, so
The energy,
so for
I mean the energy.
yeah. So for the for contralateral lateral recess decompression, you use a straight Harrison punch for contralateral.
Yeah.
Why don't you use the curved one? So why don't you rather use the curved one? Why you use the straight Harrison
他
punch?
说对侧怎么不用歪的支前，歪的枪前？
You mean the contralateral side?
Yeah, contralateral side.
Yeah. I think the 110-degree Harrison punch is very good for especially the street one is a good choice for the decompression of the contralateral side lateral recess. The street one is good, but for the proximal side, especially the foraminal area of the contralateral side, you can the curved Harrison punch is a good choice. Maybe next case, I will show you the decompression of the foraminal area by the contralateral sublaminar approach. I will use the curved punch.
Okay. Thank you, for the result.
But
Yes.
next case is not easy for me. I will try.
Good luck. Good luck.
Yeah, good luck.
Thank
So
you. Thank you.
Usually we use curved Harrison punch for ipsilateral decompression. It's easier to resect the medial side of the SAP. And for the contralateral decompression, the straight one is okay, is good. But for the foraminal, maybe you need a foraminal. So we will see Dr. Zhang Wei how to use the Harrison punch. Okay. And other any comments, Dr. Wu?
I think one comment I had